My first video will be something which I recently started doing. I have no financial interest, good morning everyone, in any of these devices or instruments or anything I'm talking about. A few days ago, let's say just a month ago, I had this thing of operating with a 3D microscope of Zeiss. It is called RTO800, which I'm not sure how many in the audience have done that. The biggest advantage for me is whenever you do a 3D microscope, you can do heads-up surgery, which is the biggest advantage for me because I had an accident in 91 in which I damaged my neck, and for me to sit for long hours like the video I'm going to show you, which is a little long, not the cataract, I have a problem in which my neck used to become very stiff by the end of the day. So when they brought the Zeiss microscope, I loved it and I'm going to definitely buy it. Like I told you, I have no financial interest in any of these things which I'm talking about. This is a new era in ophthalmic visualization, the 3D microscope, in which you are sitting in front of a microscope and you don't have to bend your head or anything. Your back is straight, your neck is straight, you take off the binoculars, you have a huge 3D screen in front of you, and you can move your back and neck anywhere you want and you go on operating. The problem here is I don't have a 3D setup in which I can show you the actual surgery done on 3D. So I have operated on 3D, but this is what you are going to show you is a 2D recording. It has outstanding depth. It has so many advantages. The biggest advantages for me is I can sit anywhere and operate. You can see the screen is so huge, and you can see everybody can move everywhere and watch it. You just have to wear your 3D glasses and operate. And this, to me, given the day, is a drop nucleus. Normally for this drop nucleus, I would have called none other than my husband, who is also a vitreoretinal excellent surgeon. But this particular case, I said I'm going to start with the 3D surgery, and if I'm in trouble, I'll call you. But believe me, I ended up finishing this case. So this is how it was done by one of my trainee, and had a drop nucleus sent to us. So I'm planning a gluedial in this case. For any gluedial surgery, the surgeons who operated there in that operation theater have actually done a good job and sent it to me with the suture on either side, on the side port and in the main entry, and put just air and send it to me. The nucleus is lying there on the retina, which I'm going to show you just now. So for any gluedial surgery, you cannot have viscoelastic. You have to have fluid inside the eye, which can be either a trocar AC maintainer or a Blumenthal's AC maintainer. But in this case, I've gone a little behind the limbus and I put a trocar for infusion throughout this thing. I removed the air. And this is another very good device. I don't have any financial interest, designed by Agarwal. And he made a very nice flap marker for 180 degrees apart, be it a horizontal or a vertical incision you're going to create. It has to be 180 degrees apart. The side port incision is made under the sclerotomy, and you have to create a 22, under the scleral flaps, you have to create sclerotomy with a 22 gauge needle. And then I removed all the remaining cortex, everything, epinucleus, everything, through the vitrector, which went through the 22 gauge sclerotomy under the scleral flap. Once I finish doing that, then I'm going to show you how I brought this nucleus out. All this time the fluid is on, and then I started doing the two other port, in which I'm actually now doing a 3-port vitrectomy. I visualized all this is done under the 3D microscope. Once you catch this nucleus, I tried it with the vitrector first in the aspiration mode to bring this nucleus out of the eye. I could not do it. Then I moved on to something once again started by Ashwin. This is a soft tip cannula which actually holds the nucleus in aspiration, and then I'm lifting it out and bringing it out. I am not a vitreoretinal surgeon, I'm only an anterior segment surgeon, but I don't know how that particular day all this came out so well. With the left hand, through the sclerotomy, I've gone with the globe stabilization rod, I'm holding the nucleus there in place, and with my right hand, I made an incision and brought the nucleus out fully. So half my job is done. Once I finished doing that, before I could even close the thing, I took a 3-piece intraocular lens, and I have brought one haptic out, externalized, which Dr. Amar was just explaining to you. With the handshake technique, I brought the other haptic also out. On the left hand side, if you see, if I don't want to use my assistant, whom I don't trust that they will damage the tip, I took just a small piece of the IV set tubing and made a hole inside that, pass it through the 26 gauge needle, and then brought this haptic out and left this part of the tube there, the IV tube. Now this haptic is safe, so that I can manipulate and bring out the other haptic, externalize it there, and then I'm going to do the remaining portions. Just you are seeing me doing that. Iris has gone inside. I sutured the main port. After suturing the main port, then thoroughly, then you can suture all the other things which you have thing. Then we'll create your Gabos chariot pockets. Gabos chariot is a great friend of ours who taught us how to do the stucking of this haptics. Enough of haptic was externalized, triamcinolone injection to see if any vitreous is in the anterior chamber. If there's anything, you can remove that. And last but not the least, you see the pupil with so much manipulation has not round and it is irregular. So a single pass 4-throw pupilloplasty, which again is a very, very useful tool for all of us to stop optic capture and leave behind large pupils. It is a very simple solution for all these irregular pupils. You take a 10-O, a 9-O proline suture, pass from one end, but see to it that it doesn't go to the cornea. It should go through a paracentesis incision. On the left hand side, you take a 26 gauge needle, pass your needle through that, bring the loop out. Once the loop is out, you cut the other end and put the suture 4 times into the loop. That's why it is called only single pass. Only one time the needle has passed inside the eye, and 4th row has put there, and then when you oppose it, the pupil has come down to normal. So if I want, I can even do this. So once I finish doing that, now I'm going to do stromal hydration, and before I even remove this fluid, I have to put in air. I have sutured it thoroughly, all the wounds, removed all those things which I have created for my 3-port vitrectomy, sutured those incisions also, and last but not the least, I removed my fluid and sutured that also. So everything is sutured very nicely. Take the glue, which is a combination of fibrinogen and thrombin. So you open one vial, you can actually do about 5 to 6 cases. I not only glued the scleral flaps, I glued the conjunctiva, I glued the incision, everything, and left the patient with very good vision on that particular day. Thank you very much. That was my personal experience with the 3D microscope, and I'm going to move on with my other videos in a while. Why is it not going back here? No. Gaurav, Jesse? I want to get out of this video, yeah. I want to move to the next video. Yeah, it's not going back. You have to come here on this one. Yeah, this second. Yeah, yeah. I'll manage. Okay. My next video is going to be something which we normally see and we keep ignoring it. So I'm going to show you something of my experience. You see this white ring here. This is a ring which we normally see, which is nothing but a white ring behind the iris, which can be 360 degrees in the eye. And this ring has been left alone and patient has been left aphakic. And in my animation, I'm going to show you how you have to manage this ring, remove it from the eye, and scaffold an intraocular lens. You saw all the steps which I showed you earlier. Scleral flaps created, intraocular lens, which acts as a scaffold. The Someringer is going to act as a scaffold for this intraocular lens, and I'm going to remove it only after I implant the lens inside. If necessary, use hooks to enlarge the pupil and remove this thoroughly using the in 3-piece lens as the scaffold, which is nothing but you're creating your own posterior capsule. All this is an animation. Sommeringering is nothing but if you see that if you had a traumatic cataract, or if your patients are very, very young, and for some refractive purposes, you just do a decision and needling, take out the center of the nucleus, and leave the remaining parts there itself. You do not put a lens inside. Patients have remained aphakic, and these lens matter which is left behind will form addition to each other, and when the patients grow, these form a ring which is 360 degrees, and it will go under the iris and remain there. It will not do anything. No literature show that these rings have gone behind. So, but the patients are aphakic, so the patients are referred to us for treating the aphakia, which I am going to show you how we treat this. So, this is a Sommering ring. I am once again planning to do a glue dial in this case. Flaps are created 180 degrees apart. These are very, very easy to create. If you are doing trabeculectomy, you have to do a partial thickness scleral flaps, but this challenge here is they have to be 180 degrees apart. If the wide to wide diameter in the horizontal meridian is more than the vertical, then you can shift to a vertical glue dial also, because overall the lens which you are getting in India are not more than 13.5 millimeters, and you have to have enough haptics externalized to put them into the Gabor-Charier's tunnels or intrascleral pockets. Everything is same what I showed earlier. Under the scleral flaps, 22 gauge sclerotomy, which is just 0.5 to 1 millimeter behind. And then I'm creating my main port, and I'm going to tackle this ring after putting my intraocular lens inside, which is a 3-piece intraocular lens going through the main port. Someone is helping me to undo that lens so that I hold on to the tip of the haptic. In your glue dial set, you always have to have at least 2 glue dial forceps. I have no financial interest. Epsilon makes such good glue dial forceps that you can take from them. You have to have at least 2 or 3 for your handshake technique, because you have to hold the haptic when you are externalizing the trailing haptic in one hand and then transfer it to the other side till you hold on to the tip of the haptic. If you hold this haptic anywhere else and externalize it, that particular haptic will come out a little deformed, and it might even break. Then you have to remove it and then transplant another lens. Intrascleral pockets are created with a 26 gauge needle, partial thickness. Now I have to remove this Sommering ring, and I'm just not going to do this just like that, because I'm without visualizing. If I'm going to pull it out, I'm going to pull traction on those zonules which are sitting there. So I'm going to enlarge the pupil on one side 180 degrees and visualize this ring. There are a lot of additions. These rings are not going to come with my cutter. So what I'm going to do is I'm going to use a cutter and break these additions which are formed in the equator between the capsule and the remaining cortex, everything, and these are really adherent to each other. So you have to break this addition first and make them loose and bring them anteriorly. Now I'm not scared that they are going to go behind, because my IOL is sitting there as a support. So that's why I called it an IOL scaffold, which is nothing but creating your own posterior capsule. Once I finish doing that, I've gone with the phaco handpiece actually and remove those rings, because they are not going to come with this cutter, which is at 23 or 25. So once you finish doing that, then you can shift this iris hooks onto the other side and do the same thing with the Sommering ring. Bring it anteriorly, use your intraocular lens which has been externalized haptic, and the optic is there, and remove the additions. Tackle this ring from one area to another till you remove this 360 degrees apart. But this ring is going to be everywhere under the iris, and so after removing the addition, using the phaco emulsification probe, I am going to remove the ring entirely, and then I have left only with gluing this flap which I have created, and check if the pupil is coming round or not. Before you remove the fluid which is there, you have to put in there, because your field has to be very, very dry when you put this combination of fibrinogen thrombin, which is a tissue glue made by Baxter. And once you do that, you have to not only glue the flap, you can glue the conjunctiva, glue your main port, glue the side ports, whatever you have created everywhere, you can glue all this with this 2 ml, and you can also use it for the next few cases. So this is how the patient look post-operatively 2020. We have tackled many Sommering ring patients like this by doing glue divals. Do you have time for one more? Last? Okay. I'll do it. I thought I'll share one more last video with me since I have a little more time. This is a Marfan syndrome. the patient has been referred to us for managing this case. Like I told you, when you measure the diameter of Y to Y diameter of the cornea, here the horizontal diameter is bigger than the vertical diameter. And the intraocular lenses which you are getting overall 13.5, you have to externalize at least 2 millimeters of the haptics outside, and you have to tuck them. So in this particular case, we are going to do a vertical glue dial. In other words, the flaps will be created at 12 o'clock and 6 o'clock, and I'm sitting temporarily. So this is a vertical glue dial in a Marfan syndrome. Conjunctiva is cut. You have to do mark the center before you could do anything to see where exactly you are going to place this lens. Scleral flaps are created, partial thickness scleral flap. There's nothing difficult in that to use. Once again, fluid is infused inside the eye. A side port is created for all this. But in this particular case, I am doing a vitrectomy through the anteriorly. This is a very, very easy lens, but when you are doing this lensectomy, be careful when you come close to the iris. If you, by mistake, should not chew up the iris when you are going to actually finish it. In this particular case, since I also told you that the overall diameter horizontal is more than the vertical diameter, also I am going to be safe in this case. What have I done here? Under the scleral flaps, before I created the sclerotomy, I have taken the cutter and I am doing a peripheral iridectomy, because in this case I have to come anteriorly to create the sclerotomy, so that I am going to go through the iris and bring the haptic through the iridectomy out, so that I have ample haptic for me to tuck inside. So a peripheral small iridectomy using the endoilluminator I have done, and my sclerotomy has gone through the iridectomy. Instead of touching the iris and making it bleed, I have created a peripheral iridectomy, and my needle, 22 gauge needle, is gone through the iridectomy and it has come forward. Once you finish doing that, finish off the lensectomy, the remaining lensectomy, which is very easy because these lenses are very, very easy to tackle. But when you are coming close to the iris, be careful, lower all your parameters and do it safely so that you do not chew up the iris. We don't need any capsule, so you can even take away this capsule, because we are going to anyway do a glue dial in this case, intrahaptic scleral fixation. We are going to bring it out. So I'm going to remove the capsule also, and peripheral iridectomy on the other side also, and through the iridectomy the sclerotomy is created. And once you finish doing that, peripheral iridectomy may prevent any iris damage. So you have to you are coming actually 0.5 to 1 millimeter anteriorly, so the remaining steps are the same. Hold on to the haptic and externalize it. Assistant is helping me to hold the flap up. Once I come out, either you can give it to your assistant, or you can put an IV tube tag and leave it there without the assistant, and manage the other haptic to externalize it. Once you finish doing that, I'm going to show you that there are enough haptics which are come outside. Suture the main port. Once you finish suturing the main port, you can take the 26 gauge needle, create intrascleral pockets or Gabor chariot tunnels, and tuck these haptics inside. They should not be too much deep, they should not be too much superficial. Too much superficial, they'll erode out. Too much deep, you will not know how far you have gone inside. So if you want to take help, you can take the tip of the globe stabilization rod and paint it with blue ink, and then just check the tunnel where it is, how far it is gone inside, and then only tuck the haptics inside. So once you finish tucking the haptic, all your job is over. You can see that this lens is centralized so well. So at the end of it, I'm going to make the pupil round. So I've taken my glue dial forceps and pulling the pupil in all the side and seeing that there's no optic capture. The pupil is round and nice. And if you want, you can use even intraocular pilocarpine, air in the AC, stromal hydration, suture your main port before you remove your fluid, because you want a bed to be dry when you're putting the fibrinogen and thrombin. Fibrin glue application is done, pupil is round, air is inside, no hypotonia. You have to check all this and then only leave this patient. Post-operatively, this patient look 20/20 vision, and you can see the peripheral iridectomy. It is not very big. Suppose it become bigger than this, and if it is coming here, then there's no harm. You can do a pupilloplasty there and make the pupil still small and round. Thank you very much. These are my videos which I wanted to share with you, and